Okay, so back to some ethics from my ethics lecture. And these are kind of all spaced out, and I do apologize for that. Um, okay, so some of the greatest challenges in healthcare is placing information in the computer applications while trying to uphold traditional principles. So one challenge involves balancing two competing values. So free access to information and then protection of privacy and confidentiality. So technologies help protect healthcare information. So in paper-based patient records, access control is almost entirely manual and procedural. Technological security tools are an integral part of the EMR system, and they offer varieties of advantages. So we think about confidentiality and privacy, information data security, the appropriate use of informatics tools in a clinical setting, and then who gets to use what tools, right? The role of system evaluation and the obligation of system developers, maintainers, and vendors, and use of computer to track clinical outcomes to guide future practice. So, importance of computer applications in healthcare. At the highest level, it serves 5 key functions. So, availability, and that's ensuring that accurate, up-to-date information is available when needed at appropriate places. So most EMR systems discuss real-time information and data, and that's because it keeps everything at an up-to-date speed. So you might think, I don't really get what you're saying. So if you wanted to look up your line infections in your hospital, for those of you who work inpatient. So now it used to be you had to aggregate that data and you would get it on a quarterly basis. Now you can have it up to the second of that day, which can be really, really helpful. Accountability. So ensure that healthcare providers are responsible for their access and uses of information are based on documented need and right to know. So accountability, right? So we are accountable in the fact that we must access information to get our data. So taking that time to actually do it so that we are making good decisions, and also limiting on how much we get, right? So if reading somebody's psychiatric information is not applicable to what you are doing with the patient, then you don't need to read it and you shouldn't read it, right? It's right to know. Um, um, for those of you who work in psych, especially in the forensic units, I think we have one psych student in the past. I know we had several. And you know, psych nursing is a very very interesting area because you're not just doing psychiatric. There's a lot of medical things that are involved. But anyway, thinking about their private information, including their past criminal history, and sometimes you do need to know that because it's going to affect the way you take care of them in a sense of their therapy if you offer counseling. But if your clinical role has nothing to do with knowing what their past was, then you don't get to know those things, and accessing that information would be inappropriate. Perimeter definition. So knowing and controlling the boundaries of trusted access to the information, both physically and logically. So one of that is, you know, we think about physically, well, password protection, intranet versus internet, and then of course, logically, how we protect things. So role limited access, enabling access for personnel only to information essential to the performance of their jobs. So when these EMRs are designed, they have that in mind. So if somebody works as a CRR, so a clerk, their charting information is going to be really limited because there's that perceived temptation to access information that they won't need, but also there's just no need for it to be there. And why eliminate, or why even expose someone to the risk of accidentally accessing something they weren't supposed to and then having to face those consequences. Comprehensibility and control. So ensuring that record owners, data stewards, and patients can understand and have effective control over appropriate aspects of information, privacy, and access. Now, I know there's many of you who probably can share this same story, but you know, the information owner is not necessarily the patient, correct? You have a chart, and that is actually owned by the hospital. And getting that information, you don't get all of it as a patient. You have to request it. People often get quite upset with that. Can I take home these labs? Well, technically, there's some paperwork that has to be filled out. Now, of course, so many people take home their labs, and that is it is what it is. I mean, but that is definitely inappropriate. Um, or when somebody says, I want all my records, I want all my charting and documentation. They don't have access to all of that. Even though their name is on the chart, they don't have access to all of that. So there are three general classes of technological interventions to improve system security. So deterrence depend upon the ethical behavior of people and provide reminders and oversight to reinforce those standards. Obstacles directly control the ability of a user to get information, right? It's literally like a huge barrier standing in front of you. And its one goal is to constrain access only to information for which they have a right to need to know. System management precautions involve proactively surveying an information system to ensure that known sources of vulnerability are eliminated. So one thing at university they used to do is check to see if same last name people were accessing charts. So were you accessing charts of your family? So it's been shown that deterrence, alert, reminder, and education of users are really effective in all of that, together with highly ethical behavior of the great majority of health providers, right? People are really good about not leaving protected information anymore in their car. People are really good about not sharing passwords, because we have this really multi-pronged system now, and with good reason. We want to protect our patients. Systems will record the identities and circumstances of all users accessing information, and that these records are reviewed regularly. Ethical users will think twice about abusing their privileges. So technologies applicable to information system security management. So there's alerts and reminders that reinforces user ethics. Audit trails, so that's document access and will give alert. Authentication, so determine who is connecting. Authorization, defined who can access what level of information. And we have this argument all the time in the EMR. Sometimes I'm like, oh, I wish I could access this information. I don't have authorization because it maybe is just at a higher level. But it's there for a reason. It's there to protect patients. Integrity management, so ensure information content is used as intended. Digital signature, so this validates notes and orders. Encryption, this prevents eavesdropping or people hacking into your system. Firewalls and network services, the same. Rights management tools, so control information distribution and access. A really good example of that is, you have a patient who goes to hospital A for their rheumatologist, and now they want to switch to hospital B, and as their primary care nurse case manager, you're helping expedite that, and rheumatologist B asks for records from rheumatologist A. Well, you might have access to those records, but you don't own those records. They're not yours. So it's not yours to print them out and to forward them. You actually have to give them the fax information to hospital A and tell them you have to get it yourself. And not in a bad way, but because you don't want to be the one who's giving information that you don't have ownership of. So there's software management, guard against viruses, Trojan horse, etc. And then system vulnerability analysis tools detect unintended system vulnerabilities. So the consensus among healthcare CIOs, which is Chief Information Officer, is that the most important threats to patient information confidentiality are the following, in decreasing frequency of occurrence. So from inside the patient care institution, accidental disclosure. So a medical personnel makes innocent mistakes and causes unintentional disclosure. A conversation may be overheard. So here's an example. Lab technician may notice test results for an acquaintance. Information may be left on a computer screen, email, fax, misaddress. I know sometimes one time I walked into a room and I said Mr. So-and-so and it was Mrs. So-and-so. It was sloppy, but it was inadvertent. Insider curiosity. So medical personnel abuse their record access privileges out of curiosity for their own purposes, right? So if I were to look up my medical records, which I don't, some do out of concern for one of their employees, like, oh my gosh, uh, Joe is in the hospital. Let's read why he's in the hospital. Some want to know about celebrities being treated, and was actually something that happened in Cedars-Sinai with not Dennis Quaid, that his kids had the medication. It was a famous celebrity where they were hacking in. And of course, that nurse who hacked into Britney Spears records. And I, it was that, she lost her job and she actually had to pay quite a huge fine. And that hospital lost a lot of money. Some may be concerned about the possibility of an STD in a colleague that they're dating. So that is not appropriate, right? So insider subordination, so medical personnel knowingly access information and release it to outsiders for spite or revenge. That is really bad. So it said that Nicole Brown Simpson's medical records were available to the press within a week of her murder. That's really awful and sad, and somebody sold it, and they never found out who it was. And of course, this was in 1994, so imagine how much more access we have now. From within secondary user settings. So uncontrolled secondary usage, those who have access rights, patient information for purpose and support of primary care can exploit that access for other purposes not envisioned in the patient care forms, like data mining. And then we will continue this on the next lecture.